Today we're doing a physical examination of the chest and lungs and the heart. First, the chest and lungs. Step one is to inspect the chest, front and back, and note the thoracic landmarks. First, we'll inspect the chest on the front and back and note the thoracic landmarks for size, shape, anterior-posterior diameter, symmetry, color, superficial venous patterns, prominence of ribs, and tracheal deviation. So for tracheal deviation, you're going to look and make sure that it's midline and there's no tug on the trachea. And the landmarks are the mid-sternal line is here, the right and left mid-clavicular lines, right and left, going from the clavicle down. And then the axillary lines, okay, put your arm up and then turn towards me. Okay, the mid-axillary line goes down the center of the armpit, and then the posterior and anterior axillary lines, anterior and posterior. Okay, you can turn back. And the vertebral line and the right and left scapular lines. So the vertebral line on the back goes down the spine, and the right and left scapular goes down the center of the scapulus. Next, you're going to evaluate respirations for rate, rhythm, or pattern. I like to do that with my vital signs, and I like to do that when I take the radial pulse and count the radial pulse, and then I look at the patient's chest and abdomen for their respirations without them knowing. Otherwise, they will, if they know that you're looking at their respirations, they will breathe differently than normal. Respiratory patterns would be normal, 12 to 20 a minute. Bradypnea is below 20. Tachypnea, or below 12. Tachypnea is above 20. Hyperventilation is over 20 and deep. Then there's sighing, air trapping, Cheyne-Stokes, Kussmaul's, Biot's, and ataxic. My patient is breathing normally at a regular rate. Next, I will inspect chest movement with breathing for symmetry and use of accessory muscles, and look at the trachea for midline without a tug, and there was no tug. And for accessory muscles, you're looking at the muscles, the sternocleidomastoid, between the intercostal spaces, you'll look for retractions, any retractions in the accessory muscles. That indicates difficulty with breathing. Then you will note any audible sounds with respiration, such as stridor or wheezes. And next is palpating the chest for symmetry, thoracic expansion, crepitus, grating vibrations, and tactile fremitus. So you'll feel the chest for any grating or crepitus. And then if you want to kind of, get your back. Thoracic expansion, you can put your thumbs together on their chest, and then as they're breathing, breathe in heavy. You're going to make sure that your thumbs are going out and in symmetrically. Alright, you can turn back around. Next is direct or indirect percussion on the chest. You're comparing sides. For diaphragmatic excursion, percussion tone intensity, pitch, duration, and quality. So percussion tones should be like, that's how you do percussion. And it should be flat over muscle and bones, resonant over the chest area. There should be dullness over the cardiac area, and then liver dullness, stomach tympany, and then flat over the spinous processes and scapula and heavy muscles, and then there's visceral flatness as well. Diaphragmatic excursion, if you could turn your back again too. Okay, so go ahead and take a deep breath and hold it. Okay, you're good. You're going to percuss along the scapular line until you locate the lower border of the diaphragm by the change from resonance to dullness in your percussion. And you'll do that on both sides and mark it. And then you let them breathe, and then you'll have them take another deep breath and exhale all the way and hold it. So if you breathe, exhale all the way and hold it. Okay. And then you can percuss again and find the next mark and mark that, and then you will measure between the two with a ruler, and it should be between 3 to 5 or 6 centimeters. Okay, you can turn back on. Okay. Next, you will auscultate the chest with your stethoscope diaphragm from the apex to the base, comparing the sides for the following: intensity, pitch, quality, and duration of breath sounds, adventitious breath sounds such as crackles, rhonchi, wheezes, friction rubs, and vocal resonance. You will hear bronchial breath sounds over the trachea, bronchovesicular below the clavicles, in between the scapula, and vesicular over the periphery of the lung fields. And you will listen in a side-to-side pattern. It's pretty normal. And you'll want to listen on the front and back for the lungs. You can also listen for bronchophony by having the patient say 99 as you listen, egophony as they say E as you listen, and whispered pectoriloquy. They whisper 1, 2, 3 while you listen. Okay. Also note if they have any cough and whether it's dry or moisture, the frequency, regularity, pitch, loudness, quality, and circumstances, and note if they have any sputum along with that. And let's see. We do all that. We palpated, we percussed, we also did. Okay. Some abnormalities you might find with the chest and lungs are asthma, atelectasis, bronchitis, pleurisy, pleural effusion, empyema, lung abscesses, pneumonia, influenza, tuberculosis, pneumothorax, hemothorax, lung cancer, or cor pulmonale or pulmonary embolism, or in infants, children, and adolescents. You might hear respiratory distress syndrome, diaphragmatic hernias, cystic fibrosis, croup, epiglottitis, tracheomalacia, or bronchiolitis, and with older adults they might have COPD, including emphysema, bronchiectasis, or chronic bronchitis. Okay. Now we are going to do the assessment of the heart. First, we've obtained a history for heart disease and taken blood vital signs, including blood pressure in both arms while the patient is sitting or lying, then sitting, then standing. Also take pulse, rate, rhythm, and volume. Alright, first you're going to inspect the precordium for the following. You'll be looking at the chest, the bare chest, for the apical impulse, any pulsations, any heaves or lifts, and you can check the capillary refill time on the fingers. Next, you're going to palpate the precordium to detect the following: apical impulse, thrills, heaves, or lifts. And you want to palpate while feeling the carotid pulse. Okay, and then palpate. and then the base. Okay. Next, you're going to do percussion to estimate the heart size, but that's optional because it doesn't give you very much information. You can find the heart size also by auscultating. Then next, you will auscultate in each of the 5 areas while the patient is breathing regularly and while holding the breath in sitting, supine, and left lateral recumbent positions. And you're listening for the rate, rhythm, S1 and S2, any splitting of S1 or S2. You're going to listen for an S3 or an S4 or any other heart sounds such as snaps, clicks, friction rubs, or murmurs. Okay, the 5 areas that you will be listening to. In the, let's see, count the intercostal spaces going down. In the second right intercostal space at the sternal border, you'll listen for the aortic area. And then you'll move over to the left sternal border, second intercostal space for the pulmonic area. Go down to the third space for Erb's point. And then to the fifth space for a tricuspid area. And then the mitral area will be at the midclavicular line in the fifth space. And you'll listen for the location of PMI, point of maximal impulse. While listening to the heart sounds, you want to listen to S1 and S2. Listen to the systolic pause between S1 and S2. Listen for the silence, murmurs, any early, late, or mid. Listen for clicks, and listen to the diastolic pause between S2 and S1. Listen for the silence, any murmurs, the opening snap, and if there is S3 or S4 heart sounds. If there are any murmurs, you're going to assess for timing and duration, the pitch, intensity, pattern, and quality. The patient is breathing normally, and then you'll ask the patient to hold their breath on expiration and auscultate again, and you'll be listening for S1 while palpating the carotid pulse, and S1 should coincide with the rise of the carotid pulse. Diastole should be longer than systole, and then have them inhale deeply, listening for S2 to become the 2 components, the split S2, during inspiration, and the split S2 is heard best in the pulmonic area. Okay. Next, you'll inspect the extremities for any edema, the capillary refill, or venous engorgement. You will evaluate the hand vein measurement, and you can measure jugular venous pressure and hepatojugular reflex, and then palpate peripheral pulses, the carotid, temporal, brachial, radial, and ulnar, femoral, popliteal, posterior tibial, and dorsalis pedis on both the right and left sides. And you can auscultate for bruits over the carotid and temporal arteries. And that's it. Any abnormalities on your heart assessment could include bacterial endocarditis, congestive heart failure, pericarditis, cardiac tamponade, cor pulmonale, myocardial infarction, myocarditis, conduction disturbances, atrial flutter, sinus bradycardia, atrial fibrillation, heart block, atrial tachycardia, ventricular tachycardia, ventricular fibrillation, or sick sinus syndrome. And with infants and children, there may be tetralogy of Fallot, a ventricular septal defect, patent ductus arteriosus, atrial septal defect, acute rheumatic fever, Kawasaki's disease. And with older adults, there may be atherosclerotic heart disease, mitral insufficiency or regurgitation, angina, senile cardiac amyloidosis, and aortic sclerosis. The end.